Welcome back to Healthcare Rounds, your insider access to the healthcare industry. I'm John Marchica, CEO of Darwin Research Group. Thanks for coming today. Just before we get started, I wanted to say that from time to time, I like having entrepreneurs on Healthcare Rounds. Some great ideas, some great innovations come from people who've spent time in the corporate world and then gone off on their own to do something new. And that's what we have today. So we have Jasmine Bhatti, who is CEO of Navi Nurses. And I've got a whole bunch of stuff on background, but instead of me reading that, I'm going to ask you, Jasmine, to please tell our listeners a little bit about your background and also to say thank you for taking the time to be here with me today.
Hi, well, thank you so much, John, for having me. It's an honor to be here and share my story. And I'm really excited to just help share what it is that I've accomplished so far and really what's inspired me to do that. So I've been a registered nurse for 13 years now, and I left Mayo Clinic. Actually, I'd spent my last 8 years in practice there to actually build my company. And I actually never thought I'd become a nurse. That wasn't my plan. But when my grandmother was diagnosed with head and neck cancer, we took her home. And at the time, we didn't have anyone in the family that was in the medical field. And we didn't really understand options, and we didn't really understand what everything would look like. And so when the physicians told us, we've got to send her to a skilled nursing facility, my family and I were just really adamant about taking her home and caring for her ourselves.
Sure.
So during that experience, I realized that insurance doesn't really cover very much, right? Like we had maybe 3 hours of visiting nursing care a week, and she had highly complex needs. She had a tracheostomy and she had wounds, and she was getting food in her belly, right, through a G tube. And it was that experience that, number one, really inspired me to become a nurse, because I got to see what nurses do for the first time and really understand their power. And the second was just, it inspired me to build my business, because as we know, about half of people who leave a hospital don't even qualify for any home nursing care. That doesn't mean that they wouldn't want it or they wouldn't benefit from it. And those that do, they often report it takes too long for it to start, or it just is not enough for them. They feel left hanging. And so this is what I'm doing now. I took my entire experience, both as a family caregiver and now as a nurse, to build a solution that hopefully helps nurses find their joy again and love what they do, while also helping improve patient outcomes.
It's exciting. I do travel in entrepreneurial circles and small business circles, and it's a common story, but usually when somebody has a very personal experience, that can encourage them to say, hey, I see an opportunity here. There's something that's, and in your case, we're talking about healthcare. We're talking about, your was your grandmother or your mom? I'm sorry.
My grandmother, yeah.
Your grandmother's life, right? And how her quality of life and what that's going to be. And it encouraged you and your nursing experience and time at Mayo to say, hey, I see an opportunity here. So once you start thinking about, because I can go back to my early entrepreneurial experiences, but once you started thinking about that, how did it sort of crystallize into, okay, now I'm going to create a company that is going to be dedicated to helping, care for people in the home, and then what that looked like. What was the process like of going from, being a corporate warrior or a nurse in the sort of healthcare setting into doing it yourself? What did that look like?
Yeah, so I think there were like a constellation of things that happened to really help get me to this point. I think the one thing in healthcare that we don't talk about very often is that I think there's a lot of shame in healthcare, either when you are diagnosed with something or when you're a family caregiver caring for someone. And so we don't talk about that a lot. And so it wasn't until I became a nurse that I realized that what I thought was unique to my family, and I really wasn't, that so many people are struggling, and it's not something we hear, right? It's not like something you talk to your friends about, like I needed to hire extra help to come and help my family and I, or I just felt so uncomfortable taking care of my loved one and I didn't know what to do. Those conversations don't really happen. But when I was at the bedside, my patients would just tug at my clothes all the time and they would say, "Hey, can you come home with me? We'll pay you to come home." And that's against hospital policy to do that.
Right.
And so I think that was a first aha moment for me, realizing that, gosh, what I went through wasn't unique, right? Because we don't talk about it, it felt like what we experienced was very unique, and it's not. Um, Lots of people need extra support and help. And so I was just always that nurse carrying a book around in the hospital with all the ideas of things that I want to do differently, right? Like questioning, why do we do things this way? Because as we all know in healthcare, there are so many areas that we need to improve on. And I started my PhD at ASU because I always knew that I was meant to do something bigger in healthcare. I didn't know what that looked like. And I ended up actually taking my ASU 101 students around to the Health Entrepreneurship and Accelerator Lab and listening to one of the professors just talking about all the amazing innovations that are happening in healthcare and how to get more involved. And so he was just a great source of inspiration and actually connected me into the university to start to build my company using resources from the college. So using marketing students and law students to help build contracts and design what does marketing look like, and engineering students for building tech. So that was a really big part of what got me going. But I will say also, having worked through the pandemic and working on a COVID unit, by the time I got to that point, I was just like, I've got to get out of here. I was so burnt out as a clinician that I knew I had this idea, and now it's now or never. And I needed to take that opportunity to step away, knowing fully that as a nurse, I can always come back. And that was a nice just guardrail for me.
Yeah, I think a lot of folks too, they think about that kind of now or never, like it's the right time and it may never be a good time again. A lot of people post-COVID, as you know, a lot of healthcare workers, nurses, doctors, they decide to retire. Decide to completely get out of the game or do something non-clinical, non-patient focused, not or patient facing. So it was interesting um, that you took the approach that you do. Now, one of the things that I'm very well aware of, and having studied this here and having some personal experience in this area as well, is that care transitions from the hospital to the home are absolutely critical to the success of that patient. And I know that a lot of health systems, they understand this, and a lot of discharge planners, they understand this, right? But still, I think we fall down a lot in this area. So what are some of the areas that when you were putting things together, and maybe now that you're of your established company, um, that you've identified as being important things to focus on for care transitions, maybe even some low-hanging fruit that you felt that good home care could address once in the home? So talk a little bit about that around care transitions.
Yeah, and I think I'll just start with that. As a nurse working bedside, I would discharge patients home all of the time. And I never fully understood what they go through during the transition and immediately after. And so I think if I were to go back today, my practice would look entirely different in terms of how I would help support people in getting them set up for success, because it is a really rough transition. And we have a partner that we're just learning and studying what our model of care looks like. And when we were first exploring what their problems were, one of the interesting things we found was that most of the calls that come in for people needing help after they're discharged happen within the first 10 hours. And of that, specifically, it's that first hour being home that they really need additional support. And I think what we're hearing from our clients and participants in our study is that by the time we get them home, it's not just being home. They have to now learn everything that we've taught them in a hospital environment, and now figure out how to do it with their own like space in their own bathroom and their own bedroom and picking out their beds. And so I think there is an actual physical difference between hospital and home that we're seeing, that kind of throws people off. Like they don't know how to adjust in their own environment always. The second big problem that we see actually is related to medications. Oftentimes people will come into a hospital and they're not always describing what they're taking as far as their medication regimen accurately. And part of that is like they're not feeling well, or their family is the one relaying the information. So the accuracy is not the greatest from the moment they come in. And what that does is it sets them up just on a poorer path all the way through the time that they're discharged if we don't know exactly the medications they're taking and when and how, because then that impacts what medications we send them home with. And so that's a challenge right there too. And then I think there's a lot to be said about family caregivers. We are expecting family members to know how to almost become nurses overnight because of the amount of care that some of their loved ones need. And that's what we go to school for and we learn. And no matter how much we show them in the hospital, what we're hearing from these people getting them home is that it's really hard for them to learn in the hospital. It's actually a lot easier for them to learn at home, and they feel so much more comfortable and relaxed. And just changing that environment for people, it makes a really big difference on their confidence, which then impacts how well they can actually care for their loved ones or for themselves.
Yeah. And that reminds me, can you just, for the audience, for the listeners, um, explain the difference between private duty or home care, or as our mutual friend Bob Roth says, in-home care. Oh my gosh, I can't believe I'm going to botch this. In-home care services. There's another word that I'm missing. If Bob listens to this, he's going to call me afterwards and say, why did you get this wrong? But anyway, the difference between the sort of home health care versus the kind of thing that you're talking about that crosses over. And I think that's the reason why that when I'm thinking about our friend Bob does not like the term non-medical, right? So talk to us about the difference, because I think it really matters in understanding, the kind of care and then how we're paying for it and how it's being delivered.
Yeah, thank you for asking that. That's like a really, really important question. So when I go back to my grandmother as an example, she had home care ordered for her. And what that means is a physician says that um, a certain person, based on all of their needs, they require extra support. And home care that's covered by insurance is inclusive of things like nursing care, physical therapy, occupational therapy, whatever it is deemed that that person needs. And depending on your type of insurance, you will qualify for different amounts of care. One of the things that we see, for example, is people who are on Medicare tend to have less resources with their home care experience that's covered by insurance. So they have less coverage in terms of what's coming out to their home. Um, Caregiving is non-medical, so they're not specialized in helping you uh, go back to a normal state of being, right? Not having the therapy, not having the nursing care when you need that. And that's more support with things like getting you dressed and ready in the morning, or it could be taking you grocery shopping, helping you around the house. So they're more basic tasks of just like companion care plus making sure you're safe and you're okay. What we do in private duty is we fill the gaps from where insurance isn't covering enough. So, like with my grandmother, for example, when she would only get 3 1-hour nursing visits a week, um, we can actually now provide with a private duty side up to 24/7 care with nurses, which can be really helpful for someone like my grandmother who had a tracheostomy, or people who go home with pretty significant wounds or drains, and they're trying to manage complex new ways of being. Maybe they've had a heart transplant and they need to be just watched more carefully. And what we do is help continue their care plan and encourage them to, stay active, eat the right foods, get the right sleep, and helping to support them where home health that's covered by insurance has very limited time with people.
I think that for most people, I've had this conversation at parties, which is why people don't invite me to parties much anymore. But I've had this conversation, and for the average person, even for the healthcare executive that may be in healthcare 20 years, so this distinction doesn't make sense to people. Just so you know, you've been in the industry. The distinction between I'm going to change a wound versus I'm going to check your prescriptions, or I'm going to take you to Walgreens to get something, or take you to Walmart, whatever, doesn't make a lot of sense to people because it feels like a lot of the same thing. But having said that, is it safe to say that when you're caring for somebody in the home, that maybe some kind of combination of, like yourself, an RN, so nursing care, and then I don't want to say non-nursing, but somebody who doesn't have maybe it's a CNA, or maybe not even just a caregiver that can help with so many other things, that has that sort of spillover help too, but it's not really, doing the kind of nursing thing that you went to school for. Does that make sense?
It does. And that's actually really helpful for people who are wanting to age in place. So for older adults who want to stay at home and stay as independent for as long as possible, one of the best things to do is to have them supported with caregiving services. And what we do as nurses is come in and we track their changes as they age. We look at their vitals. We can stay on top of communicating with their physicians and advocating for the changes in medications or different support things that we can tap into to help keep them at home as long as possible. And that's what the research shows. So the research shows that when nurses can actually come in and assess and make sure people are taking their medications and they're not taking too many as they're aging, they can actually age at home longer. But we don't want to be there 24 hours a day. We don't
Right.
need, right? Nurses want to work to their capacity. And this is where caregiving can come in and play a tremendous role, especially with older adults. When we well, I guess what I should say is what we really focus on are getting people home from the hospital. That's the biggest need. And so
That transition.
that transition. Yep. So like for that first 24 to 48 hours where someone is most vulnerable and they don't have a call light anymore, and they still are at risk for complications, that's where we can come in and keep a super watchful eye and ideally transition them to caregiving if they need to, or hopefully by the time we leave, they or their family feel comfortable and confident managing everything on their own. Like that's the optimal state. So really the high intensity practice from our side is really focused on getting people transitioned from home, or actually at end of life. We do those both. So helping people pass it home with their loved ones, and we provide 24/7 care there too, because hospice, again, only covers a small portion because of, again, insurance limitations. So we can fill in around that.
Like so many things in healthcare, it seems like it's one of those situations where a little bit of investment, a little bit of spending, and this is where the issue always comes in, right? Because budgets, and we're going to spend more on home care, and we're going to spend more on home. The latest MedPAC recommendation, I think, for home health care was, of course, a decline. I think maybe there's been one recommendation to increase in how long? I mean, years.
Yeah.
So there is the sense of we're trying to keep costs under control, and now you're asking to spend, but the spend is the investment. It's the same argument that drug companies make. If you just, in a sense, if you just take the medication, as prescribed through the, take it and not half it and not do any of these other things, then you'll get better outcomes. But then you have to spend money on that medication. It costs more money. And so there's a trade-off. I don't know where I was going with that, Jasmine. I'm just saying it seems to be one of the challenges. And look, I mean, we're the day before an election. Both presidential candidates have said, and that's not a political podcast, so we're not asking you to get into that, but both first, Harris said through Medicare is going to pay for home care, and I imagine increasing home health in some way. I think Donald Trump has also said something along these lines, maybe through tax breaks or other things, tax incentives. But again, it's like it almost feels like this is the first time that we're actually getting presidential level talking about home care, right? And it doesn't seem in my recent memory that it's even gotten a mention. Now it seems like it's part of the conversation in healthcare to the degree that they're not just yelling at each other and saying about how much they don't like the other candidate. I mean, it's really come to the forefront.
Yeah, and that's really important. So I think, what is it? About a fifth of all of our spending in the US goes towards healthcare. And
Yep.
we're actually not even anywhere near the top of having the best quality. And so I think healthcare as a whole needs to be addressed. And that's really important for either candidate, whoever wins. But I also believe that actually supporting caregivers has a tremendous economic impact for people, because what we find, especially a lot of our clients who hire us, they are the caregivers who are hiring us to come into the home. They are their children oftentimes that are responsible for caring for their older parents. And in this case, they're taking time off of work. They are then not as productive. This causes companies to lose a significant amount of revenue and productivity. So even if we think about the impact that if we can reduce the burden on family caregivers, that economically makes a really big impact for the actual organizations and companies in our nation. And so that alone is really significant. So I'm glad to see that it's part of the conversation. It needs to be, because we have just this ever growing population of adults who are getting older and they have really complex health conditions, and they're going to be going home with a lot of things to manage, and we have to be able to support them and their families to be able to withstand conditions where people can still work, because there are a lot of people who leave work entirely to care for their aging parents, and they really shouldn't be.
That's a really important point. And I think, when I started, when Darwin Research Group started looking at home health care, is probably 15 years ago, one of the first things that I started studying from a research perspective. And it seemed to me that in almost every circumstance that you could think of, home care was a better option, right? As soon as you can get somebody out of the hospital and have them taken care of at home, where they feel safe and where they're protected, and then like the financial side of it, a third the cost or less. So it seems like we're ready for it, and especially with the emphasis in the last 10 years on readmission rates. I'm assuming one of the things that you're going after in that care transition and wanting to be there right away in the home is to prevent them from going back into the hospital, correct?
Yes, and actually that's one of the things that we're seeing. We're able to impact the likelihood of someone being readmitted in a certain time frame, and then whether they get readmitted multiple times versus one time. And that's really important, not only for the system, which loses about $56 billion a year in readmissions, but it's also important for the person and their family, because every time they get readmitted, they go back more frail than the last time, and it makes recovery even harder. And then you think about the financial implications for a readmission for a person and their family, like that's significant as well. And so the value of just paying it forward with having a nurse come out and help support you getting you home to prevent that from happening it can be invaluable, right? It brings peace of mind for the family members that there's someone in their home that they know and they can trust, that knows what to do. And we make it a lot easier. So if we do recognize that someone needs to get readmitted, we can actually start that process sooner, get them going faster. And what that means is then if they are readmitted, it's usually a shorter stay. So they can get in and out a lot faster.
So, not specifically to Mayo, your former employer, but if you think about just generally these health systems, do they understand this argument for home care and home health? Do they get it? Do they understand? Like if you were talking to, because I know that health system people listen to this podcast. So if you're making your argument, well, A, do they understand it? And if not, like what would your argument be to those that are just sending thousands of patients home to be cared for at home, not necessarily with the kind of care that you're talking about?
Yeah, I think they understand. I think that what the problem is that in healthcare right now, we're so reactive and we're still recovering, I think, from a lot of the setbacks that we had during COVID, and staffing is an issue. We're losing more clinicians. There's just so many problems. There's not enough coming in through the pipeline. And so there's a lot of things we have to fix at the same time for things to really get better. I think people are
Sure.
with it and they see it, but it's a question of how. Right. So how do we make these things happen? And I think a lot of that is just how do we use technology? How do we stop doing healthcare the way we've always done it and the way people think it needs to be, and how do we do it in a different way? And sometimes that change can be hard, and systems are pretty big, right? Creating a change in a system is not an easy task. It requires a lot of meetings, a lot of yeses, and a lot of time and preparation. So it takes a while for a change to be implemented. And so they have to be very thoughtful about, is this the right approach? Are we doing the right thing? And I don't necessarily think that this is an area that's been explored enough to really have the right data. Like we're still understanding what are the best home models look like. How do we get more primary care back in the home? How do we help more caregivers in the home? We're still learning those right now. And so as the data comes in, I think hopefully that will help drive picking the right directions and how do we do it the best way.
Yeah, I mean, from my thinking, it seems like, and one of the reasons is entirely anecdotal, so I don't have data on this, but it seems like that in the health system or the IDN world, that there's been some pretty notable systems that have exited the home health business, say home health in general. And I think what it comes down to is they recognize the issue, and they certainly recognize the issue around care transitions. But unless you're talking about a high-tech hospital at home, right? The Hopkins of the world, the Mayos of the world, right? And actually some more traditional systems having those capabilities now. Unless you're talking about that, it's a totally different animal than the kind of care that they're used to delivering in the hospital. And it's very different from the kind of primary care that you give in the doctor's office, right? And so I'm thinking that some of it is, as you said, you're still learning, still amassing data on the benefits, but just in general that it just feels foreign to them and just a money losing enterprise. I don't know, but it seems like, not that this, and I want to be careful about what I'm saying here, not that these health systems don't think that home care is important or valuable or any of that. It's just that maybe they don't think that they're the right vehicle to do it, and that an external, somebody who specializes in that might be better suited. I don't know. Are you seeing something similar, or is this just my own sort of anecdotal view of what some systems are doing?
Yeah, I think my view is kind of anecdotal, just like yours. So I think what I'm experiencing, what I see is that a lot of hospitals are struggling to just keep the staff that they do have, not even thinking about how do we grow? How do we bring on more nurses? How do we bring on more clinicians? I think that alone, how do we create healthy work environments, and how do we support our staff and keep and retain them? Because that, again, is another big loss for them. That's a big part of it. And I think kind of wrapped around into that too is just the idea of how clinicians are reimbursed for the services they're delivering. And again, that goes back to this, that political discussion as well, is that we really have to have reform on payments and the reimbursement. And I think there's a lot of different ways that can be tackled. And there's ownership on multiple parties, right? In with insurance companies also having a role in the care delivery and what this looks like. And so I think insurance companies should be using more data driven information to guide what it is that they're paying for.
Have you set up in sort of this the new company and the new model? Have you been setting up anything to measure the outcomes that you're getting, so that then in turn you can go to these health systems, or you can go to employers or whoever that you are looking to convince that you have, real world evidence of the kind of work that Navi Nurses does?
Yeah, and so let me just kind of back up a little bit to explain what it is that we're doing, so the measurements make a little more sense.
Sure.
With our model, what we do is our nurses actually go to the bedside when someone is getting discharged, and then they get report at the bedside, and then meet them at home directly and spend a few hours with them at home, getting them all set up. So making their appointments, making sure that they can afford their medications, they have them, helping them navigate which room they're going to sleep in, organize all their medications. So they really get them all set up for success. And during this intervention, we actually have been able to collect data on both patients as well as the nurses themselves. And one of the pieces of data that is just incredibly important to me is related to nurse burnout. So our nurses who are performing this intervention, they work at the bedside. So they're working in hospitals. They do this on the side, which is exactly what I want. I want to keep nurses working in hospitals because I want high quality nurses caring for me and my loved ones when I go into a hospital myself. So
Sure.
I don't want to take them away. What we're finding with our nursing staff is that even though they're working on average maybe 8 hours a week with us, they're actually significantly less burnt out than the nurses who just work in a hospital, which is counterintuitive because with all of the literature, we see that the more hours a clinician works, the more burnt out that they become.
Yeah, it makes common sense.
Yeah. And so it's really interesting to see that now we're having these nurses work more, but they're able to work in a way that they love, and they're able to practice to their scope, and they're autonomous, and they get to be nurses providing one-on-one care to someone and really focusing on that person. And what we're finding is that the nurses are happier, they're less burnt out. And what that means for systems is that less burned out nurses are less likely to leave, and they're more likely to have
Yep.
better patient outcomes in their hospitals. So I'm hoping that working in collaboration with systems, I can help support their staff, improve their turnover by decreasing it, and helping them have happier nurses who give better outcomes to the patients in their own institutions. So that's one of the biggest, really, I'm obviously being a nurse, that's what's really most impactful for me. I think nurses, they deserve so much more, and they deserve to be happy and love what they do again. So that's important. But we're also seeing tremendous benefits from the patients as well. So we've collected qualitative and quantitative data. The quantitative data is still coming in, but we are impacting readmissions. And just what we're hearing from their interviews is, in the beginning, they didn't know what this meant, going home with a nurse. What does this look like? Because again, it's a new way of doing things. But when we asked them in the end, would you want a nurse to come home with you like this in the future? Every single one of them, they're saying insurance should pay for this. Hospitals should pay for this. I can't imagine not going home with a nurse ever again. Like, it's so impactful for them.
I believe it. Have you done any research on the family members?
When we actually put our proposal together, we had included caregivers, the family members, into the research study, but we quickly realized that they're actually a really difficult group to get to. So when we go in and we consent people to participate, we realize that the patient themselves would often defer everything to the caregiver and say, I don't need help and support. I have this person at home who's caring for me. When in fact, it's that caregiver that really they need the help. They can benefit from all of the support that we can bring in. And so again, it's just not something we talk about. Like if your parent gets sick, for example, John, like you as a son or if you have a sister, it usually goes to the female in the family. But that responsibility typically falls on you and you own that responsibility. And so
Sure.
as a family member, you don't usually say, oh my gosh, I can't do it. And you don't tell your loved one, I don't feel comfortable. Like you just usually say, okay, well, I've got to do this. Whatever it takes, I'm going to make it happen. And so again, there's that shame and vulnerability in that caregiving aspect that we started to see. So we kind of pulled away from looking at that for this particular data collection. But now that we're seeing a lot more, I think it'll help inform how we research that in the future.
Well, I could continue talking and talking and talking, but I think that we have a limit on time on this one. But I do want to ask one final question, which is you to look in your crystal ball and ignoring the fact that we have an election coming up, and I'm sure the policy implications of that, depending on who ends up winning, will be different. But what do you see just sort of in the next couple of years? You're in it. What do you see is on the horizon for home healthcare in general? Like, are you seeing an uptick in interest? Are you seeing an influence of technology? Like, what are some of the things that we should be looking for in the next year or two as it relates to caring for patients in the home?
I think all of the above to what you just said. Number
Yeah.
one, there's a lot of interest in the health tech space to help keep people at home. And there's just so many different angles that that's coming from. And that's going to be really exciting to see what happens, especially with all of the AI and
Mm-hmm.
different tools that we can use to help make predictions about people just from their home environment. I think that's really exciting. That's going to be a really big movement, I think, over the next few years. And then, secondly, just we have so many people still aging, right? We've got this aging population, and we're going to start to see a lot big, greater need for home care as our population ages, specifically because they have children who are still in the workforce. And so we need to come to some solutions quickly to help keep their children working and fulfilling their own lives and not taking on that burden of being caregivers. So I'm hoping that there's some policy changes. Again, like what we're seeing with the elections right now, allowing families to actually not be fully responsible in the way that they've been required to in the past. So I definitely see a lot more push for caring for people at home, and hospitals really becoming more of a place where you're there for really, really acute episodes, right? Like you're there because you're really, really ill. Like we're learning how to manage people who need IV antibiotics and the basic hospitalizations at home. And that's really exciting because that's where people will heal the best. And that's where they're going to really be set up for success in the future.
Couldn't agree more. Jasmine, how do people get a hold of you and how do they find Navi nurses and all of that?
Oh, okay. Well, great. They can actually, email me directly. That's fine. So my email is Jasmine, Jasmine at navinurses.com. Or you can just visit the website, www.navinurses.com. And that's NAV as in Victor, nurses.com.
Excellent. Jasmine Bhatti, thank you so much today for spending some time with me. I hope we stay in touch, and I wish you the best of success for your new venture.
Thank you so much for having me. It was a pleasure.
Well, that'll do it for another episode of Healthcare Arounds. Our guest today has been Jasmine Bhatti, CEO of Navi Nurses. As always, I'm your host, John Marchica, CEO of Darwin Research Group. And as I say every week, or every time I do these, rate and record us, please, because that's how people find the content. If you don't rate and review, I said record, rate and review, then people don't know to find it. So please do that. That's it for now. See you next round.